Right heart failure is most frequently a consequence of left-sided heart disease. However, Cor Pulmonale describes a specific subset of right heart failure that exists independently of the left side of the heart. Cor Pulmonale is defined as an alteration in the structure and function of the right ventricle caused by a primary disorder of the respiratory system. Right ventricular dysfunction secondary to left-sided heart disease or congenital defects is excluded from this classification. Mechanically, the right ventricle is a low-pressure pump designed for a high-compliance circuit. Cor pulmonale occurs when pulmonary vascular resistance increases, forcing the ventricle to work against a pressure overload that induces changes in its morphology. The right ventricle adapts to this pressure based on the timeline of the vascular injury. Distinguishing cor pulmonale from secondary right heart failure is necessary for clinical management. While the symptoms may overlap, the underlying pathology requires interventions that target the pulmonary circulation rather than the left ventricle. This condition follows two divergent clinical pathways, acute and chronic cor pulmonary. Acute cor pulmonary is typically triggered by massive pulmonary embolism or injury from positive pressure ventilation in patients with acute respiratory distress syndrome. Because the pressure increase is sudden, the right ventricle cannot thicken its walls in time. Instead, it undergoes rapid dilatation and failure. Chronic cor pulmonary develops over an extended period, most commonly due to COPD, though it can also result from interstitial lung disease or untreated sleep apnea. Persistent hypoxic vasoconstriction and vascular remodeling allow the right ventricle to compensate through progressive hypertrophy, thickening the muscle to maintain output against high resistance. A chronic, compensated state can be suddenly destabilized by an infection or a new embolism, resulting in an acute on-chronic crisis. Establishing the timeline of the injury allows the clinician to anticipate whether the imaging will show sudden dilatation in an emergency setting or compensatory hypertrophy in a chronic care environment. Isolating the pulmonary origin of right heart failure follows a four-step diagnostic cascade: clinical signs, ECG and biomarkers, echocardiography, and right heart catheterization. Phase 1 relies on clinical suspicion. Early symptoms are nonspecific and frequently masked by existing lung defects. As the condition progresses, signs of systemic venous congestion appear, including jugular venous distension with a prominent V wave, hepatomegaly, and peripheral edema. A physical exam may detect a palpable left parasternal lift and an accentuation of the pulmonary component of the second heart sound. Phase 2 utilizes electrocardiography and blood biomarkers to screen for right-sided strain. The electrocardiogram reflects the physical changes of right ventricular hypertrophy, showing right axis deviation, peaked P waves, or P pulmonale, and the S1Q3T3 pattern. Serum biomarkers provide a measure of cardiac stress. Elevated high-sensitive troponin levels indicate myocardial injury, while brain natriuretic peptides signal right ventricular overload. These signs confirm that the right heart is failing, but they do not definitively prove the failure originated in the lungs. Phase 3 involves transthoracic echocardiography, which provides the primary non-invasive assessment of right ventricular anatomy and function. These echocardiographic diagrams illustrate morphological changes of the right heart. The top left view identifies right ventricular enlargement in the parasternal long axis view. Dilation is assessed by comparing the ventricles. A right-to-left end-diastolic ratio greater than 1.0 marks severe pressure overload. This pressure forces the interventricular septum to shift toward the left, creating a D-shaped left ventricle in the short axis view. To evaluate systolic function, clinicians measure the tricuspid annular plane systolic excursion, or TAPSE, using M-mode imaging. A TAPSE value below 17 millimeters indicates depressed longitudinal contraction of the right ventricle. In acute cases, a four-chamber view can reveal McConnell sign, where the right ventricle apex contracts while the mid-free wall remains akinetic. The 60-60 sign combines a pulmonary acceleration time under 60 milliseconds with a peak systolic gradient below 60 millimeters of mercury. While echocardiography provides vital morphological data, it remains an estimation and cannot definitively rule out the influence of left-sided filling pressures. Phase 4 is right heart catheterization. This invasive hemodynamic monitoring currently stands as the absolute gold standard for diagnosing cor pulmonale. The primary objective of the procedure is to demonstrate right ventricular dysfunction in the absence of left ventricular dysfunction. Pulmonary hypertension is confirmed when the catheter records a mean pulmonary artery pressure greater than 25 millimeters of mercury. To isolate the cause, the pulmonary capillary wedge pressure, which estimates left atrial pressure, must remain below 15 millimeters of mercury. If the wedge pressure is higher than 15, the right-sided failure is being caused by back pressure from the left heart, which excludes a diagnosis of primary cor pulmonale. In chronic cases, the ratio of TAPSE to pulmonary artery systolic pressure can be used to assess right ventricular pulmonary arterial uncoupling. If the right ventricle fails to pump effectively, cardiac index may drop below 2.2 liters per minute per square meter, causing systemic cardiogenic shock. Right heart catheterization is the final arbiter, providing mathematical proof that the pulmonary circuit, not the left heart, is the definitive source of the failure. Bringing these diagnostic steps together creates a unified matrix to distinguish between acute and chronic presentations. This table summarizes the parameters used to stratify patients and assess the severity of the right ventricular failure. While clinical symptoms and biochemical markers like troponin and BNP are present in both acute and chronic states, imaging metrics allow for differentiation. The acute profile is defined by sudden dilation with an increased right to left ventricular ratio, preserved wall thickness, and specific imaging signs like the 60-60 or McConnell sign. The chronic profile is identified by right ventricular hypertrophy, where the wall thickness exceeds half a centimeter, and a progressive decline in exercise capacity as measured by the 6-minute walk test. Precise diagnosis is also required for accurate medical classification and clinical documentation. Under ICD-10 coding rules, chronic cor pulmonale is reported using code I27.81 and must be linked to the underlying pulmonary disease. Acute cor pulmonale is reserved specifically for patients with pulmonary embolism. Standard heart failure therapies, such as diuretics or digitalis, have limited efficacy in this context compared to their role in left-sided failure. Effective treatment must target the underlying respiratory condition, aiming to alleviate hypoxemia, reduce hypercapnia, and lower the vascular resistance in the lungs. Cor pulmonale is a condition where the lungs drive the failure of the heart. By following a strict diagnostic sequence to isolate the pulmonary circuit, clinicians can identify the correct path for intervention before the right ventricle collapses.